Today we'll see a very crystal clear case of acute anterolateral wall MI or myocardial infarction. Now this is very wonderful ECG because this has a very nice findings of a typical anterolateral wall MI. So whenever we see this ECG, what we say is we always go for an ST elevation whenever a chest pain patient is coming to our OPD clinic or casualty. Now what we have to say is as soon as we see lead one, so one of the most important thing that we need to understand is we have to always see lead one, lead AVL, lead V5, V6. These are contiguous leads. We have to see lead V1, V2, V3. These are more of anteroceptor or anterior leads. V1 to V6, these are all anterolateral leads, and lead 2, 3, and AVF, which are called inferior leads or inferior wall leads or posterior wall leads. So these are more of a contiguous leads, contiguous leads basically. Now whenever we call it as STEMI or ST elevation MI, the criteria is the chest lead should have ST elevation of more than 2 millimeters. That too in two consecutive leads means it has to be V1 V2 or V2 V3 or V3 V4 or V5 V6. So this has to be two consecutive leads. And if it is limb lead, it has to be more than 1 millimeter, that too in two consecutive leads. So lead 2, 3, and AVF, these are consecutive leads, not lead 1 and 2. These are not consecutive leads. Lead 2, 3, AVF, these are consecutive leads basically. Okay. So coming to our again ECG. So what we can see, what actually ST elevation is, if we can see this lead 1. Now lead 1, first we have to form a baseline. So ST elevation, whenever we call it as elevation, we need to have a baseline line, and the baseline line is this. So we have to simply follow this baseline. So this is the baseline. So when we have found this baseline, what we can see that this basically the length of ST elevation. So this is 1 millimeter. This is 2 millimeter. So this is more of a 2 millimeter ST elevation, which is clear cut. We can very nicely make out because this is 1 millimeter box and this is 1 more millimeter box. If we know this is a box of 5 millimeter into 5 millimeter. So each small box is 1 millimeter. So this is same applied in this area also. So this is the baseline. This is 1 millimeter and this is 2 millimeter. So this is 2 millimeter ST elevation in lead 1. Same in a lead AVL also, but it is slightly difficult to understand in AVL. So I won't give example of this. We can very crystal clear see the same thing in lead V5. So in V5, this is the baseline which can very clearly draw. So there is estimation of lead 1, 2, 3, and 4 up to 4 millimeters. So here also 1 millimeter, 2 millimeter, almost 3 millimeters. So ST elevation of 3 millimeters is seen in V5. In V4 also we can see that this is the baseline. This is 1, 2, 3, and up to 4. So 4 millimeter ST elevation is there, and which is crystal clear. The ST elevation is also seen in V2, V3. So in short, it is not only involving the anterior leads, which are V2, V3, it is also involving V4 and V5. It means it is involving lateral wall as well. So lead 1 AVL, V5, V6 suggest lateral wall, and V2, V3, V4 they all suggest anterior wall. The second thing is key, this ST elevation, if it is associated with ST depression, what we call it as a reciprocal changes. What we call it as a reciprocal changes. So if reciprocal ECG changes are there, then it is almost 100% sure that this is an acute MI or acute cardiac event. So in this case, we can see that there is marked ST depression in lead 3 as well as in lead AEF. So we can very crystal clearly see that the ST has markedly reduced. So compare the ST depression in lead 2, which is not marked, but in lead 3 it is almost 4 millimeters. So 1, 2, 3, 3 to 4 millimeter. So estimation of more than 12 millimeters in more than 2 consecutive leads in a patient presenting with chest pain, shortness of breath, or palpitation or uneasiness is all crystal clear MI. So this is in short STEMI. This will label it as ST elevation MI, and the primary treatment for this is PAMI. This is primary angioplasty or primary coronary intervention for acute myocardial infarction. And if it is not feasible, then thrombolysis has to be done as fast as possible with elaxin or injection streptokinase that I'll talk in the next video. Thank you so much.